Good morning, everybody. I'm Marie-Louise Meng. I'm a cardiothoracic and an obstetric anesthesiologist at Vanderbilt University Medical Center. And this morning we're going to be discussing how to care for the patient who has cardiac disease, who is pregnant. And let's begin. My disclosure is that I do serve on advisory boards for BD. So this is a refresher course. So the goal is to bring everybody up to speed with how we care for these patients. And something really exciting happened at the end of the summer. The European Society of Cardiology released the newest iteration of their guideline for the management of cardiac disease in pregnancy. So I would recommend that everybody downloads this, has it easily accessible on their labor floor, because this document is incredibly rich. It also has supplements that have really useful information about how to care for these patients. Certainly can't go through all of that content today because there are many different types of cardiac disease and all of these women will be cared for differently. What we will review is the fundamental principles on how to plan these deliveries. A big part of this document is that they really are stressing that the pregnancy heart team is a real multidisciplinary team. Cardio-obstetrics is a field. We do exist. These patients exist. And of course, all of you here in the room know how important this is. That's why you're here. But creating these teams and these systems is really what helps our patients have better outcomes. And they highlight that the anesthesiologist is a crucial member of the pregnancy heart team. We're included there in the central component of that wheel, and we're included in the central figure about delivery planning, the anesthesia plan. So today we'll review the epidemiology of cardiac disease in pregnancy, the physiologic changes that happen in pregnancy, labor and delivery, and postpartum, how we plan for these cases. We'll review a case, and then I'll just do some of the highlights from the guidelines. So everybody is well aware that maternal mortality in the United States is all too high. And it's very different by states. So 18 per 100,000 live births in the best states, up to almost 60 per 100,000 in some of our other states, particularly in the Southeast. We have a real issue. And cardiac disease is still the leading cause, when you add up cardiac and coronary conditions and cardiomyopathies, of maternal mortality. And this is true across all races and ethnicities. And it is important for us to highlight that Black women in the United States have a 3-fold higher rate of dying in pregnancy or within 1 year of pregnancy compared to white women. What is not shown on this graph is also the Alaskan, Native, and American Indian women. They are just as high, if not higher, than Black women, their risk of death in pregnancy. So let's get to pregnancy and what is happening physiologically. And I believe if we fundamentally understand that pregnancy is a state where the maternal blood volume is much higher than normal, we can understand everything else that is going to happen through pregnancy and postpartum. And as anesthesiologists, it helps us control her hemodynamics. So her plasma volume has increased. So our x-axis is time through pregnancy. And once that plasma volume's increased, she needs to compensate for that. And the way she does it is increasing cardiac output. So if she can't augment her cardiac output, we're going to see heart failure. So this should not be a surprise. We need to help her augment her cardiac output. So in the first trimester into second trimester, we know it's heart rate times stroke volume, that's cardiac output. So her heart rate's going to increase and her myocytes are going to contract a little bit harder and increase stroke volume. If those things do not happen, we see heart failure. Again, it should not be a surprise. Pregnancy hormones cause a relaxation in peripheral vascular resistance. And also the pulmonary vascular resistance needs to decrease. So if those things do not happen, blood pressure does not come down a little bit, and there isn't a greater venous capacitance for all that fluid, you will see increase in blood pressure, preeclampsia, and you will see in patients with fixed pulmonary pressures, pulmonary hypertension. So just think about that big blood volume going through her body, coming up to her heart, right heart and left heart, need to augment in order to push that blood volume through. So she reaches labor, and now we know she's gone from her normal cardiac output to about 7 liters a minute just being at term. Now she starts contracting, you're going to get about 300 cc's of fluid into the vascular system with every uterine contraction. So through that, she needs to continue to augment her contractility up to as high as 10 liters a minute. This does not end when the baby is born. She still needs to get rid of all of that pregnancy fluid. And I think if all of us pay more attention to our patients in the immediate postpartum time, we'll catch and prevent a lot of unnecessary heart failure and arrhythmias if we're able to help her get that fluid safely off her body. So the birthday party does not end with the birth of the baby. As anesthesiologists, we really need to be stepping into that recovery zone and helping her continue the augmented cardiac output till she's back to her baseline physiology. So she's in pain, she's anxious, and all of this produces lots of catecholamines. She's contracting. We just discussed the autotransfusion that comes with that. And then when the baby's born and the placenta comes out of the uterus involutes, contracts, it moves off the IVC. With that relief of aortocaval compression, you've got an even bigger blood volume up to the heart. She will bleed. Maybe she can handle delivery, but can she handle bleeding and a perhaps necessary resuscitation? And through all of this, there is an increase in oxygen consumption. So I want you to think about vaginal delivery as somebody who is working out and training for a marathon, right? Your right heart is seeing little preloads with every contraction of the uterus, and right heart is getting used to this. If we take our patients who have cardiac disease and we say, oh, she's got cardiac disease, let's just do a C-section. She's unlabored, she comes in, right heart has not had any acute stresses that it has had to remodel and get used to. And you deliver the baby and everyone says to me, everything was fine until 10 minutes after delivery. Again, this shouldn't be a surprise. Fetus out, placenta out, uterus contracting, moving off IVC. Out of nowhere, you're getting a liter of fluid a minute up to the heart, and right heart is not used to that because that kind of just happened out of nowhere. For that right heart, if she's got a cardiomyopathy, if she's got any cardiac compromise, she's going to go into heart failure. This is no surprise. So if you think about it like this, it becomes very simple because we know what her heart and her cardiovascular system need to deal with through this. So we all know these formulas very well, and so what I like to do is draw this out for our obstetricians or our nurses or our trainees so that we understand, based on her specific cardiac disease, how do we need to help her get through this. So all that increase in catecholamines, we think, well, that's going to lead to tachycardia and arrhythmias. Well, even if you've got the best neuraxial anesthesia, she's still going to have tachycardia around delivery and when she's doing the Valsalva maneuver. So we're kidding ourselves if we think we're preventing tachycardia. But what we are preventing is the acute changes in heart rate through every contraction because of pain. So what we recommend is early epidurals to remove pain and to remove that excess in catecholamines with every contraction. And with that, we know our anesthetic is going to decrease her SVR, and so we want to make sure that we are maintaining her coronary perfusion gradient and that we're maintaining her aortic diastolic blood pressure appropriately. Many of these patients have chronic hypertension or preeclampsia, leading to higher left ventricular end diastolic pressure, so it's really imperative that we maintain aortic diastolic pressure at her baseline. So I don't hesitate. I give her vasopressors, and whatever is necessary in a labor room, we're going to give it to her to maintain that perfusion gradient. I think I've covered the point that cardiac output is the main change that's happening here that we need to ensure is happening. If she cannot augment her cardiac output, she will go into heart failure. This should not be a surprise to us. So we have to support the myocardium, and most of the time we can do that with inotropic medications. It's really rare to need mechanical support. Most obstetric patients are not on inotropes. Those myocytes are naive to those medications, and we have a whole toolbox full of meds that we can use to get her through. So I recommend early use of inotropes so that we don't even see the heart failure. All that stroke volume, all that blood volume, all that preload is not just going through the systemic circulation, it's also going through the pulmonary circulation. So if she has fixed pulmonary pressure with that increase in flow, fixed pulmonary resistance, her pressure is just going to go up. And if that goes up, we know right heart will fail. So with all the changes in preload, we need to be constantly assessing, do we need to diurese her? Do I need to give her a pulmonary vasodilator? Let's not forget oxygen's a pulmonary vasodilator, so you can temporize with that while you get the real medications that she needs. Every obstetric patient has a decrease in oncotic pressure, leading to some trace pulmonary edema. So sometimes we may decide if she's bleeding, let's go right to red cells instead of giving her a lot of crystalloid through the resuscitation. So in summary, I still love this phrase from my clinical mentor back when I was training at Columbia from Dr. Rich Smiley. He would say, go slow. The cardiac mom is surviving right now. She walked in here with nice hemodynamics. Keep her there. Keep her perfectly train tracked. And often in order to do that, that means that we're giving vasopressors, we're giving inotropes, but the goal is to keep her hemodynamics perfectly stable through all of these changes. It's important to recognize that pregnancy and heart failure have overlapping symptoms: fatigue, shortness of breath, peripheral edema, weight gain, palpitations. And we really need to recognize when this is heart failure and act on it. The data from California, from Dr. Elliott Main, show us that when women die of cardiovascular disease in pregnancy, the reason is because we had delayed responses to clinical warning signs and then ineffective care. So I highlight on the labor floor that it is never normal for her to be tachycardic, and it is never normal for her to have an oxygen requirement. The obstetricians, the nurses, should come alert the anesthesiology team if these things are happening so that we can go to the bedside and assess her cardiopulmonary status. The fetus is a sign of end organ perfusion. So if there is a decompensation in the fetal tracing, again, if she's a maternal cardiac patient, we should take a look at her heart. So let's go through how we plan for these cases. In 2020, 2021, I was fortunate to be given the opportunity to write an American Heart scientific statement on how we do this. I had a fabulous team of multidisciplinary co-authors, everybody from nursing to CT surgery, obstetrics, cardiology, and some of our own cardio OB anesthesiologists. And so we have this very simple algorithm, and if you go through this with your pregnancy heart team for all of these patients and you make a plan and you put it somewhere in your medical record so that teams can access it, when she comes in at 3 in the morning, your colleague can already see the pregnancy heart team's thought process, and we try to keep this organized. So who is the patient and who is on the pregnancy heart team? What does she need, a vaginal delivery or a C-section? And of course, we must remember some patients do need terminations of pregnancy because they are that sick. When should we do it? Where, in what type of center, and where within the medical center should we care for her? And then, of course, the fun part. What are we going to do? How are we going to do this as anesthesiologists? So first of all, who is the patient? Meaning, what is her cardiac disease? There's many different types. We've got valvular disease, shunts, arrhythmias. Each of those have different subtypes: complex congenital, non-complex congenital, myocardial dysfunction from different causes, and of course we've got vascular and aortopathies. The European statement goes through all of these diseases beautifully and gives the best advice on what we know. Now, it's important to acknowledge that there is no American guideline, and there probably will never be, because we don't write guidelines unless we have great evidence, and it is very hard to do randomized controlled trials in patients with cardiac disease who are pregnant. So a lot of what we have are case series, expert opinion, and some epidemiology. So what is the severity of her disease? Is this mild mitral regurgitation, or is this some severe mitral stenosis? How is she doing? And this is what I encourage our fellows to do when we're doing our preoperative clinic, is ask her how she felt before pregnancy. What could she do physically? And then ask her that same question by each trimester and how she's feeling now. This does two things. One, it helps us understand her current status, but also it builds a therapeutic relationship because we're about to be bedside with her through a long labor and delivery or through a C-section, where it's really important for her to feel comfortable to tell us about her symptoms. Is she starting to have some shortness of breath? Is she feeling palpitations? Something just doesn't quite feel right. We need to hear her, and part of hearing her is letting her feel comfortable that we listen. And so I use that preoperative evaluation to give her, and it doesn't take very long to ask her what she could physically do before pregnancy and through pregnancy for her to realize, hey, I'm really not feeling well, and that's why the OBs in the NICU are recommending me to actually end my pregnancy at 28 weeks, and I will have a preterm baby, but that's better because, wow, when you make me walk through my symptoms from pre-pregnancy to now, I see how sick I've actually become. So when you have those signs of heart failure that overlap with pregnancy symptoms and you're not sure what it is, send an NT-proBNP. This test is incredible. It's got great negative predictive value. So if it's normal, you really don't need to worry about her heart. But if it is positive, you probably should be getting an echo or just do a bedside POCUS exam yourself while you're waiting for cardiology to come and do the formal echo. I love this paper from Alicia Dennis. It's over 10 years old now, but she nicely goes through all the things that we expect to see on an obstetric cardiac POCUS exam. The maternal heart is pushed upwards and anterior and leftward because of the gravid uterus. So your peristernal views are beautiful. It's actually pretty simple to do POCUS during a C-section. The heart is right there, I promise. We want to optimize her other medical history. A lot of cardiac patients have other hematologic or pulmonary abnormalities, and we're grateful for our colleagues that optimize that during her pregnancy. So it's important to acknowledge our risk stratification tools, what they're useful for and what their limitations, and we have three. The MWHO that was just updated in the European statement, so we're calling that for the first time MWHO 2.0. CARPREG 2, which was the risk score that was updated in 2018, and the Registry of Pregnancy and Cardiac Disease, which is a multi-center registry from across the globe. It's both underdeveloped and developed countries, so we need to also understand the populations and what we can really infer when we bring it back to our American populations. So this is the old MWHO. There were 5 buckets, group 1 through 4. There's a group in the middle called 2 to 3. I still don't know why they haven't just done it 1 through 5. They're still calling it the same 1 through 4 in the new update. But this was all we had, was this table, and we would look at this and say, well, the ischemic disease is not on here. And I feel like some of these should be subdivided out because all cardiomyopathies aren't the same. And so that's what the European Society has tried to do a little bit here. So as we increase in the number, we know that the maternal risk is going to increase, and this is so that we know what adverse events she's going to be prone to have and where she should deliver. And so the lower risk lesions, they can deliver at local hospitals, and the higher risk patients, we want to bring them into the larger medical centers. And it's just fantastic. So they go through ventricular dysfunction and pulmonary hypertension, arrhythmias, cardiomyopathies, congenital heart disease, and each of these buckets really describes how her risk increases. We've got the valvular heart disease, aortopathies, and the acquired coronary heart disease and other diseases. So I recommend pulling that document out with every patient and specifically looking at what you need for her disease. So CARPREG, the authors are Candace Silversides and Sam Sue. I like to call them the godmother and godfather of cardio-obstetrics. There's some incredible cardiologists up in Canada who have a beautiful prospective database of patients with cardiac disease in pregnancy. The benefit of this data set is that these women really are getting the best care possible in a great pregnancy heart team. So these are probably the best outcomes that we can have. What they wanted to do was look at the cardiac complications and the temporal trends in those complications, and then see if we could identify predictors and create a risk index so you could tell a mother what her risk of a complication in pregnancy may be. And what they found is across all types of cardiac disease, all events, about 16% of the patients had some sort of an event. The most common events were arrhythmias and heart failure events, but this also included a few deaths and strokes and MIs, but those were really rare. So when we're telling a woman she has a certain risk of an event happening, remembering that it's just an arrhythmia that actually might not need treatment, or it's a heart failure event that we get her through. So you really need to try to make it specific to her, because this is still very general. And so again, our x-axis is time, and you can see through pregnancy. In the middle, we've got labor and delivery, and this goes all the way 6 months postpartum. The blue bars are arrhythmias, and the red is pulmonary edema as a surrogate for heart failure. And these complications come from that volume expansion that I mentioned, right? So you've got your atrial stretch because she's volume up, makes you prone to arrhythmias starting second trimester into third trimester, and then when her body can't handle that volume, you start to see the heart failure events. And so let's remember, we're doing a great job monitoring her and taking care of her during labor and delivery, but look at all those late heart failure and arrhythmia events that as pregnancy heart teams we have to do a better job of preventing. And this is the CarpReg risk calculator, so you can see all of the predictors on the right, see how many she has, add up the points, and then you're able to tell her what her risk of an adverse event is. And a lot of these predictors coincide with the cardiac diseases in the higher MWHO risk groups. And when you bring the two tools together, they can be very useful. So you can have somebody with a class 4 lesion but a CarpReg score of 0, they really don't have a lot of complications. So our pregnancy heart team likes to use both of those in combination to help us understand what level of resource we may need for her. So from the Registry of Pregnancy and Cardiac Disease, they've got almost 6,000 cases across many centers in many countries. Again, this is our very diverse care cohort, so these outcomes are not going to be as great as the outcomes in a place like Canada, where their pregnancy heart team's really able to care for everybody. And so they're looking at, again, this is tip of the iceberg. 1 week postpartum maternal morbidity, mortality, and heart failure, okay? And we know there's a bunch of late events. And they really see the same thing, is that if you have signs and symptoms of heart failure, if you're in group 4 MWHO, meaning you have low ejection fraction, or you need anticoagulation, often that's a low flow state, or mechanical valves, these are the high risk conditions, you have the highest risk of heart failure or mortality. I love this graph. Time is again on the x-axis. The big blue bar is labor and delivery, and these are heart failure events. So that big light blue bar is where I think that there's a huge window for us to improve, is to reduce these late heart failure events in that first month postpartum. The second component is who's going to be on our pregnancy heart team. So lots of disciplines may need to be involved for certain patients, but you're not always going to need your ECMO surgeon on the pregnancy heart team call. But at the centers I've worked in, we basically have a meeting once a month where we run the list of patients who are imminently going to deliver, and then the critical patients that are pregnant but maybe not about to deliver, but folks that we may hear from through their pregnancy. And it takes a lot of effort to coordinate these meetings. And in anesthesiology, we're very lucky. Usually cardiology or obstetricians coordinate it. But having an anesthesia presence at these meetings is very important, and encouraging our leaders to provide time and resources to the faculty members that attend these meetings and participate in the care coordination is really important. So what does she need? That European statement really stresses that a vaginal delivery is usually preferred in our patients. And of course, it's important to acknowledge that terminations are necessary at times. So it's hard to study exactly what about a vaginal delivery is better than a C-section, besides the usual factors that we know, right? Lower risk of infection, lower risk of bleeding with a vaginal delivery. But maybe it has to do with the right heart function, right? The right heart getting used to those contractions, functioning a little bit better, rather than the right heart never seeing any fluid change and you just do a C-section and all of a sudden you have hemodynamic collapse. That's my personal theory. Very hard to prove that with science, but we'll keep trying. But that means that we have to be able to staff vaginal deliveries, right? Similar to how we staff C-sections. I'm not saying somebody has to be sitting bedside the full 36 hours of her labor, but if she needs a vasopressor or an inotrope infusion to get her through the vaginal delivery, then we should be meeting that recommendation. And so that may mean that we upstaff from an anesthesia standpoint. That may mean that we have difficult conversations with nursing to get ICU nurses bedside, or to make sure labor and delivery nursing leaders know that we are checking in with these patients at the appropriate frequency given the infusions that they're on. But no, we don't need to be sitting bedside and staffing like that. So I was asked to write an editorial for JCVA, and I think that's what we're going to be speaking about, is really how do we coordinate this? Because if you take a patient who's critical and you want to do a vaginal delivery and you move her to a labor floor, move her off the labor floor to an ICU, and you try to do a vaginal delivery in the ICU, you're not providing her with all the elements that we have on a labor floor, right? Rapid access to intrapartum C-section if necessary, oftentimes an obstetric trained anesthesiologist there 24/7, or at least an anesthesiologist 24/7, right? So in an ICU, you're not going to have that. Are you upstaffing and having somebody sitting bedside with chloroprocaine ready to go and roll her for a stat C-section? Probably not. So there can be a bit of patient compromise when we change that. So we prefer vaginal deliveries if possible, but acknowledge that there are often fetal and maternal obstetric indications for C-section, and then we go ahead and, of course, we do C-sections in these patients. So what's the difference between a C-section and a vaginal delivery? And I've alluded a little bit to these fluid changes. So it's important for us to understand the Valsalva maneuver and the maternal hemodynamics through the Valsalva maneuver. So there are 4 stages. The first 2 stages, she's holding her breath. The second 2, she's releasing her breath. The important change happens between stage 3 and stage 4. So let's go through it. So she takes a big deep breath to hold her breath to push, right? Big deep breath, and that drops her that increases her intrathoracic pressure, and that decreases the preload up to right heart. As she continues to hold her breath, now we're really empty, and left heart is empty as well. When she releases the Valsalva maneuver in stage 3, now we have a preload returning to the right heart. It has not yet been enough fluid to go through lungs into left heart, so left heart's empty. Our maternal autonomic nervous system baroreflexes sense this. Adrenal glands kick out some of our catecholamines, and maternal heart rate goes up. She continues that release, and now we're in stage 4, and we have enough fluid returning through pulmonary circulation to left heart. A left heart that was very empty is now very full. It ejects into the aorta, and that is a big shear stress into the aorta from low preload to high preload. Big hit to the aorta. So it's very clear now why patients with aortopathies, big ascending aneurysms, are told that they should not be doing the Valsalva maneuver over and over through delivery, and also patients with preload sensitive lesions, so your left-sided obstructive lesions, HOCM, aortic stenosis, mitral stenosis, and even a right heart that is in a very tenuous volume status may not tolerate great fluctuations in preload. But we don't want to say that everybody should not have a Valsalva maneuver, that everyone should have a C-section or everyone should have a forceps delivery. And the reason why is because saying that carries a real risk to the mom. So again, this is not something that we can randomize patients to Valsalva or no Valsalva. We need to look at the data, and this is nice data from Boston, of women who were told that they could Valsalva and that they couldn't. And what we see in those who don't Valsalva, meaning they get forceps, as you would expect, there are more 3rd and 4th degree lacerations, and there's more bleeding. So this is not our decision. We stand by as anesthesiologists and support what the cardiologists and the obstetricians decide together. But I think it's important for us to know why they're making those decisions for some patients. And What I'm suggesting here is very similar to what our patients suggest when they come in with birth plans, right? I just made us a vaginal birth plan saying that we prefer vaginal deliveries, early epidurals to minimize tachycardia and arrhythmias, though we know at the time of the vaginal delivery, her heart rate's going up to 150 with those pushes, right? So the next time you're in a twin delivery and you're watching a woman deliver, look at what her heart rate really does. The best epidurals are not blunting that at the time of pushing. It's really just through labor. So we're going to manage our fluid shifts. We're going to let her get to 10 centimeters, and the uterus is going to contract for a little while we gather our anesthesia tools. Let the uterus really push that baby nice and low in the pelvis so that she only needs to push a few times or not push at all. And then we're going to actively manage the third stage, and she's not going to bleed. It's going to be great. We also have a birth plan that can change at any moment, and so it's important for us to acknowledge that as well. So the European statement's very clear that heart disease is rarely an indication for cesarean birth. And the way we need to look at this is we don't have a crystal ball. When she walks in and she's going to have a trial of labor, we don't know if she's going to end up with an intrapartum C-section. Of course, we can stand there in our little anesthesia room and guess, you know what, she's toe lacking and she failed to dilate last time, so this is probably not a good idea, right? We can make our little prediction models about that, but ultimately we don't know. And so the important comparison to make is there a higher morbidity if we let a woman have a trial of labor and might have an intrapartum C-section versus a planned cesarean? And years ago, ROPAC published their data of all comers, all types of cardiac disease, elective C-section versus emergent C-section, and they found there was no difference in maternal morbidity if we allowed women to labor and they ended up with an intrapartum C-section. So we do think that it is safe for women, no matter the type of cardiac disease, to do a trial of labor if that is something that the woman wants. There are some indications for a C-section. So if mom has had warfarin, then we know that she may be, the warfarin may have washed out and her INR may be normal, but the fetus may still be anticoagulated. So those moms have C-sections. Large aortas and critical valvular stenosis, they're still recommending C-sections in those patients. And if mom is decompensating, if she can't breathe and you're intubating her for cardiopulmonary reasons, it's probably best to do a C-section, not a vaginal delivery for that patient. And before these more critical cases, I always pull the attending surgeon aside and I say, look, I can't tell you how to do your job, but if you cannot exteriorize the uterus in this patient with pulmonary hypertension, that would be great because small micro air emboli up to this pulmonary circulation may not be tolerated. And please try to do this with your most senior resident or co-attending so that this can be a fast surgery. The ICU is going to want to anticoagulate her because she has an EF of 10%. So we really don't want to have to come back for bleeding. Please, this is a senior level case. So term is 37 weeks, and I once heard a cardiologist say that past that, the only point is to retain fluid. So most of these patients, we are delivering them at term. But what I learned recently from a couple cases where women had such bad heart failure, cardiomyopathy, that they needed Impellas during pregnancy. The moment the NICU says we're ready for that baby, mom seems pretty sick, we're okay, it's time to deliver. We always worry about that baby is too premature, but at these incredible medical centers, these NICUs have really wonderful outcomes. So if they say they're ready and mom is decompensating, move forward with delivery. So it's important to identify the appropriate level of maternal care, and the MWHO and some of our other documents really pair nicely the different ACOG maternal levels of care with her cardiac disease. And if you are that accepting center, accept those patients. And if you are that center that says, you know what, I think this is above and beyond, and sometimes it's above and beyond for nursing, though your anesthesia team may be capable, she will be better served in a different place. So like we said, usually a vaginal delivery is best performed on labor and delivery, and that's because we can miss certain elements that we have that we do fabulously on the labor floor. But if you have a patient who might need ECMO standby or a cardiac surgeon on standby for some reason and you're doing a C-section, then it may be more helpful to just start that C-section from the get-go in a cardiac operating room. But I try not to make too many recommendations about this unless I see a medical center, because there are intricacies to every system. All right, so this is the fun part. We make our anesthesia care plan. And the way we do this is we go back to our basic physiology and we figure out what the greatest risk for her is based on her cardiac disease. And we could spend a whole day going through every single type of cardiac disease and what her goals are. And so I would highly recommend opening up that European heart statement every time you have a cardiac patient and just go direct to the small little section for her disease. It's really helpful. And so with medications, we really just need to gather what we need, because if we're doing this case on labor and delivery, we might not have a dobutamine or a dopamine infusion. And if you're doing the C-section in a cardiac OR, well, you're not going to have oxytocin there. So we really just need to have our little checklist of the things that we usually need. We usually prefer neuraxial anesthesia, and I say for the usual reasons plus, meaning if she's awake, you're really going to be able to tell if she's having heart failure. She's going to let you know that she's feeling a little short of breath. And that's why it's lovely to have a pairing of an OB anesthesiologist and a cardiac anesthesiologist in these cases, because CT anesthesia hasn't done a C-section since residency maybe, and they will be appropriately alarmed when she feels the pressure from the uterus being exteriorized or the rush of fluid after placental delivery and uterine involution. And you know how to talk to her and say, this is just pressure, it's just this part, let me know if it's a little bit more. And they know how to do POCUS and show you an image of the heart, and you just do it together, each with your own subspecialty. So PICS can be extremely useful, and I was fortunate to work in a center where we could get PICS pretty quickly. So if there's one action item to go home and try to implement, is that when these patients come for delivery, if you think she might need an inotrope, especially for prolonged inotropy, it's much nicer for her to have a PIC than to have a neckline. And it's not pleasant to put a neckline in a pregnant patient at the beginning of a C-section. And boy, is it elegant if you just have a PIC line. But these lines can clot pretty frequently, so you don't want to place it on Tuesday for Friday's C-section. You really want to place it Friday morning for Friday's C-section, and maybe the night before. Also with that, do we need ECMO? Do we need the CT surgeons on standby? And it's a very rare case, but that's when you take pause and say, okay, CT surgery should be involved in our planning meeting. We might need them. When it comes to hemorrhage prevention and management, oxytocin is wonderful, and I usually start my oxytocin at 1 unit a minute for the first 5 minutes, and then I reassess tone, because often that's all you have in these patients. Calcium is a fabulous uterotonic if your SVR and your blood pressure can tolerate it, so you can use calcium. But methergin, you're going to be limited if she has any coronary disease, if she's got preeclampsia or hypertension. Carboprost, I really hold off on anybody who has complications of pulmonary edema, because that can be an asthma-like picture very quickly. So if I need one of those agents and I'm deciding between them, I go with methergin, because we're very good at lowering blood pressure if necessary. Ask your surgeons to place compression sutures and Bakri balloons rapidly, so that we're not dealing with a massive resuscitation on top of cardiac disease. So when we're talking about recovery and postpartum, I think we do need to have an important hand in this when we're handing over the patients, specify what's needed from her cardiac disease side and from the usual obstetric care side, right? Most of the time, we're getting rid of that big plasma volume that we discussed at the beginning of the lecture. So what's the fluid balance? Are we diuresing her? Every single day we have a certain fluid goal that we're getting off of her. Are we restricting her sodium and not letting her have the cafeteria pizza that is going to just, go backwards on everything that we nicely did? Stool softeners, right? We said she couldn't Valsalva, so let's make sure that she's not straining in the bathroom. And restarting that anticoagulation, getting your epidural catheter out as soon as possible so she can have that if necessary. And then let's not forget the usual care. Fundal exams are really important, that mechanical pressure on the uterus to tamponade and prevent further bleeding. And of course, if she's in an ICU, we want to make sure that we can bring her baby to her and that she can pump if she wants to. So that's the icing on the cake is if we bring mom to an ICU, can we really not separate mom and baby completely? Can we have some overlap there? And where does she recover? And so I stress to the fellows when we're making our recommendations in the pregnancy heart team meeting, be specific about what she needs. Does she need telemetry, or can we skip that? Are we worried about heart failure meds that we are going to be weaning and that's why she's in ICU? Are our labor and delivery nurses too busy that they can't do good I's and O's? And she's actually just in the ICU for I's and O's and diuresis. And then if she is in the ICU, letting the ICU know what the usual OB care is and making sure that OB and OB nursing rounds on her and is comfortable doing the usual care up in the ICU. So that's a summary of our American Heart Statement and how we recommend planning these deliveries. And it looks like we still have some time, so I'm going to go through a case. So this is a patient that is 30 years old. This is her third pregnancy, and she's at 32 weeks. She does have a history of a cardiomyopathy with a known EF of 30%, and so that puts her in WHO group 4 risk. But she's now short of breath. And so the obstetrician outpatient sent an NT-proBNP that was elevated. And so they repeated her echo, and now we have an EF of 10%. So what this is decompensation. And she is at an appropriate gestational age to be delivered of this baby. She's had previous C-section, so we're going to do a repeat C-section. This is an urgent case. It doesn't need to be done in the next 20 minutes. You can bring in your appropriate expert team and take a moment to plan for this correctly. And we're going to do this in a CT-OR because with an EF of 10%, I'm 90% certain that we can get her through with inotropes, but if we can't, we will need VA ECMO support. So we're going to get a PICC line, we're going to place an A line, we're going to be prepared to do cardiac POCUS to see how our inotropes are helping her heart, and we're going to have VA ECMO on standby. And I'm going to push myself and describe what I mean by standby is if I think that there is a good certainty that she may, if there's at least a 20% chance that she might need VA ECMO, I'm going to have them place micropuncture catheters. So these are just like a tiny little arterial catheter in an A and a V femorally, so that if they need to change those over a wire to an ECMO cannula, we can. We have done this many times, and I have not needed to, in a patient that looks like this with heart failure, I have not needed to use VA ECMO for this because I go quickly to inotropic medications, and that has been very successful for me. But still, I don't want to miss a patient. That would be catastrophic. So at this level, I still recommend that that degree of support. Acknowledging that that is not a cost-free resource, taking up a CT-OR and a CT surgeon and a perfusionist, but I think that the benefit is better than the risk of missing this and having a maternal arrest. And then crash trying to urgently acquire ECMO and not be able to. And because the risk with that is that mom bleeds, and it's much harder to cannulate vessels that are clamped down because we get into bleeding. So we're going to do neuraxial anesthesia. We're going to do a low-dose CSC and bring that level up carefully. We'll give her vasopressors and inotropes as indicated, and she's someone who will recover in the ICU because she'll probably need diuresis and she'll probably need weaning or continued myocardial support. And so here are some really beautiful echo images, and you can see she's got her right heart's functioning normally, or almost normally. The left heart is dilated, and you can see where that mitral valve, those leaflets are not coapting because the LV is dilated. You have severe mitral regurgitation there. And so just as a little reminder of what a normal myocardium should look like on the right and her cardiomyopathy there on the left. And then we have our apical 4-chamber view. And so let's just quickly review how we use inotropes. So I love ephedrine because it is a quick answer that yes, my patient needs an inotrope. If you give a patient ephedrine, all of her endogenous catecholamines, vasoactive peptides are going to be released, come up to your myocardium, touch some receptors, improve your force of contraction, and if she can improve her stroke volume, her heart rate can come down a little bit, okay? A mom that is in heart failure's heart rate is going to keep elevating, okay? So tachycardia is one of the most important signs in patients with heart failure and cardiomyopathy. They are increasing their heart rate because they cannot increase their stroke volume, much like an infant, right? Why is a baby's heart rate 140? Because the myocytes in that myocardium are not yet developed. These myocytes are stunned. So if you improve stroke volume, if you improve force of contraction, heart rate can come down a little bit. So if I give ephedrine and I see that, I'm kicking myself for not pulling out my echo and looking at her heart sooner, okay? And I'm starting an inotrope. Dobutamine's great because you can give it peripherally and it's fast on, fast off. The cardiologists always ask, well, what about arrhythmias? Well, I don't see arrhythmias if I start it early enough. And if you do, you can just turn it off. And usually we're running some phenylephrine or norepinephrine, so I don't see a decrease in SVR because of peripheral beta-2 agonism. Epinephrine's wonderful. Low-dose epinephrine, very effective. So that's kind of a useful order of medications. And if I'm giving epinephrine and I feel like she needs something else, I just add dopamine on top of that. And that's something I've learned from doing heart transplants. It's beautiful to have your epinephrine going for about half an hour and you feel like you need something else. Adding the dopamine, it acts as though it's covering receptors that the epinephrine missed. So that's a beautiful combination that has not failed me yet, knock on wood. Milrinone is great because you can load it slowly over time. So it's perfect for a patient with preeclampsia with severe features and cardiomyopathy. So if you want to do a vaginal delivery in her, you can start your Milrinone at a reasonable dose and load her slowly through her course of labor. And just to be cognizant of the fact that if you were to load her, you would get a real drop in SVR. So I would do it as a slow infusion. And then, of course, we have our mechanical support. VA ECMO is really going to be the only one that provides a bit more right heart support. Your intra-aortic balloon pump is really only helping your left side, and same for the Impella. So it's important to really work with your heart failure cardiologist and think about what's going on between right and left. So these are my reasons to consult the ECMO team, meaning I want you guys on standby, I want the micropuncture catheters, or I want you to just know about this patient, specifying those different degrees. So if she's got severe right or left heart failure, particularly if she's got like a systemic right ventricle, perhaps a Fontan patient with complications, if she's got pulmonary hypertension with right heart failure, with right heart decrease in function, definitely want to have them on standby. And any unstable cardio-obstetric patient. So if mom is decompensating, then you want to have them aware of her. If I think I'm going to be using dual inotropes and any of the above plus preeclampsia, that can really cloud your picture, and it may be useful to have those folks on board. So I'll show you the anesthesia record, and you can see we're nicely train-tracked throughout it. And the most concerning thing on here is the little black dots that are her heart rate. You can see her heart rate, before I show you anything else, it's above 100, and after delivery, it doesn't come below 100. So that's my sign that this woman is not going to get better after delivery, and she's going to need to be in an ICU, and she's going to need prolonged heart failure therapy. Most of the time, if it's like a viral cardiomyopathy or a preeclampsia cardiomyopathy, after delivery, they get much better and the maternal heart rate comes down. So that's my sign that I'm not fixing her here today. I'm just getting her through to ICU so that heart failure cardiology can take over. So I do a CSE, and then like clockwork, every 5 minutes, I give her another 5 cc's of lidocaine to bring the level up. With this, I'm going to use norepinephrine instead of phenylephrine because of the additional beta agonism to help out the myocytes. And while her level is rising, there's enough, I've given enough in the spinal such that they can start on their micropuncture femoral access. C-section starts. And I'm not waiting to see heart failure. I'm just starting my dobutamine. I showed you what her heart looked like. Those myocytes weren't doing much. She delivers, And then I start my oxytocin, like I said, about a unit a minute for the first 5 minutes, and then I cut it back based on the uterine exam. I brought my dobutamine down a little bit. I usually, if I've started it in the OR, I don't titrate it completely off. I bring her upstairs on a little bit because I think it shows our colleagues upstairs that she's still a critical patient and there's still big volume shifts that have to happen. So this is not somebody that I want to wean to off and call it a win. I want to bring her with the inotrope to the ICU. Lasix is lovely. If the surgeons didn't make her bleed, it's nice to give her a dose to start getting some of that fluid off. And then a C-section ended, and I had some amazing surgeons who did that very quickly. So on the left, you can see her heart before the dobutamine, and then you can see we recruited maybe 3 more myocytes there. Not the best thinning and thickening of the myocardium, but seems like the walls are moving in and out, but this is still pretty severely dysfunction. Of course, the dobutamine did not help decompress the left heart. We still have our severe MR. But the right heart is fine. So the tricuspid annular systolic plane excursion is normal, but that's what we knew about her right heart. So she recovers in the ICU. She's got a bit of tachycardia and hypotension, so we call this heart failure, and they assist with inotropes. And she had a concern for hemoperitoneum. They ended up doing a uterine artery embolization. This becomes important later when she gets pregnant again. But 6 weeks postpartum, she still wasn't better, and so they put in a HeartMate 3. 2 years later, she wanted to get pregnant again, and she did. We transitioned her from warfarin to enoxaparin so that the fetus could develop appropriately, though she did not take her enoxaparin through her pregnancy, and she didn't develop a clot. So that's important to note, and we have since published this case. We did routine echoes through her pregnancy. Cardiology increased the VAD speed as indicated, and she had monthly growth ultrasounds. So we bring her back in, and everyone's like, oh my gosh, you have a HeartMate patient, an LVAD patient having a C-section. I'm like, actually, this is a lot easier because now I have left heart support. And what I'm really concerned about is her right heart. And like with most HeartMate patients, the right heart does at some point show a little bit of decreased function. And we're concerned about a focal accreta from what happened last time with that uterine embolization. So, of course, we do the same lines, make sure we have the large peripheral IVs, and we brought her in the night before, and we bridged, we were going to bridge her from warfarin to heparin, but she, of course, had not been taking her warfarin, so that was a little bit easier. And really, this is the exact same anesthetic, a low-dose CSC. We load the epidural, bring the level up, start our inotrope, our vasopressors, start our inotrope peri-delivery, and this is for the right heart. I don't want to see right heart failure. My left heart is mechanically supported, so I start a little epinephrine just to support that right heart. Same thing with our oxytocin, and she doesn't bleed, and we bring her up to the ICU. And so you can see this is the same heart, and there's her inflow cannula. And the MR that we all remember is still there. But that the right heart's okay. It's hanging on. But that was really our concern. So she recovered in the CTICU. We bridged her to warfarin, and she was discharged home on postpartum day 8. So that's how we plan, even if it's an LVAD patient or a decompensated patient, kind of the same thing, cross our T's and dot our I's. So I'm just going to take a brief moment here to go through the European statement. This is a new statement, and again, just download it, put it in your workrooms, and use it when you need it. It's about an 88-page document plus the supplements. So as for aortopathies, so this is, I'm going to point out some highlights, but also some areas of further research. At the top, they're recommending, based on the type of aortopathy, when they should have surgery. In between 40 and 45 millimeters, that's when there's kind of the no evidence zone, if whether we do a vaginal delivery or a C-section. If it's smaller than that, they recommend vaginal. If it's bigger than that, C-section. And in between, it's still a nice source of further research. They have some nice algorithms for how to handle arrhythmias. I think what's really important to note here, especially with AFib and AFlutter, is hemodynamic stability. If she's not stable, she needs a cardioversion. And here they say severe structural disease. If she's hemodynamically stable with severe structural disease, then she should have cardioversion. If she doesn't have severe structural disease, she doesn't need a cardioversion. But keep in mind, AFib, A-flutter with a rapid rate, okay, above 100, you cannot keep her tachycardic for a very long time pregnant. That is not safe. That is not stable. So when a pregnant patient needs a cardioversion for AFib with RVR, that needs to happen urgently. We can't be delaying that case. We can't have cardiac anesthesia up in EP not knowing what to do because she's pregnant and then the case gets pushed off. We really need to create pathways for when there's a pregnant patient in EP, in cath lab, that OB anesthesia team is called and we can make sure that care is expedited. Because a woman at 125 in AFib for hours is not going to do well, right? So sometimes the cardiologist may want to load her, may want to anticoagulate her. That's fine. We acknowledge the purpose of what we're doing, and if she truly is stable, we wait for that. But we shouldn't be delaying these very quick and very important cases. Some nice algorithms just for ventricular tachycardia. And these you can just put up in your workroom if you want. I think there's more work to do in terms of pacemakers and ICDs. Let's remember this surgery is usually below the umbilicus. So if it's a pacemaker, we don't have to change the settings. We just want to turn off the ICD and put pads on. On occasion, you might have a complicated surgery that goes above the umbilicus, but that's really rare. So generally, we don't need to touch the pacemaker settings. I think that should be a little bit more clear and firm here. The reason why it's not is because every cardiologist does it a bit differently because we all have different risk thresholds. And so there's no clear guide so far on that, but I just try to use that logic about the umbilicus. Very succinct summary of how we take care of patients when they arrest, reminding ourselves of the etiologies that are pregnancy specific, and then the factors that we do that are just the same medication choices, same chest compression, same defibrillation dose. But what do we do differently? We're going to do left uterine displacement. We're going to get our IV access above the diaphragm. We're going to remember magnesium and calcium that patients may be receiving. And if we don't get a return of spontaneous circulation, we're going to do a C-section. We're going to make sure that neonatal team is there. I really like this figure for valve lesions, stenosis versus regurgitation, and they put the red flag there. We had a patient with wide open pulmonic insufficiency the other day, and I was trying to explain to the resident why I wasn't concerned, and I said, wait, just look at this figure. It says regurgitation, usually well tolerated, red flag, poor RV function. And the patient had normal, amazing right heart function, and the resident said, okay, I believe you now. So I like this diagram. And then here, this is my last slide. I love this heart failure algorithm because it really says here, hey, start some inotropes. She's in heart failure. Do your usual heart failure therapy. And if she's not getting better, intubate her or deliver her. So it's really nice that this group put this together into this detail. So that's everything I have for you today. And I'm happy to take some questions with the last couple minutes here.
Hi, thank you for the great presentation. George Mitraska from the University of Ottawa. I'm an OB cardio anesthetist. So in terms of the example that you've given us, very illustrative, any preference for the butamine versus milrinone? We have good experience with the milrinone in similar situations. So I was just curious if you have noticed a benefit from the butamine rather than milrinone.
I just like the butamine because it works faster and I don't have to worry about loading it. So it just depends on when I'm meeting the patient and how much time we've had to start the medication. So, and also if she has a heart failure cardiologist that's already been following her and they have a preference based on her other medications, having a conversation with them. But I think, again, it's a very hard thing. We can't study this. right? We can't even study it well in cardiothoracic anesthesia with all the patients that they have here. You're really just going to have to use trial and error and your clinical hypotheses based on how she's responded previously and where her SVR is right now. Certainly if she has preeclampsia and higher pressures, I think melrinone might be a great idea.
Thank you. Precisely. The same kind of question about the choice of norepi versus vasopressin, for example, in somebody with the tachycardia for reducing the chronotropy of the...
I mean, I think whichever one is going to help you is fine. I like the extra beta agonism from norepinephrine, but vasopressin is a great choice, especially if she's been chronically ill.
Thank you.
All right, well, thank you so much for your attention.